live streaming. So welcome again. We're live and direct on YouTube and on Facebook. And hopefully people, as they find it and as we boost it, long after this event, we'll be boosting it to ensure that we really educate our Caribbean diaspora about the process of engaging and advocating for what we want that is so necessary to our moving forward. So as I started saying, we're in our second round, if you will, of a conversation on how healthcare matters for the future. We began this morning with a conversation around general post-COVID recovery, lessons we have learned, and how we might create a new normal. We don't want to go back to the old normal in healthcare. We want to take the opportunity of this pause, this pregnant pause, to birth a new reality into being. And so we're going to be joined in this session as we talk about healthcare engineering and management systems. Yes, a lot of what healthcare is about engineering. And we're going to be joined by two denizens, if you will, of this issue. Dr. Carolyn McLean, who has been looking at this for some time in Jamaica and across the region, as well as Mr. Ray Barrett, who also brings some expertise, long-time expertise in the sector. The question we're going to address in this session is very simple, and we want to ensure, number one, that the doctors and the nurses and the trained care team that are working with patients and working tirelessly to ensure that patients have what they need. We want to make sure that they have the right technical support to do what is necessary. So that's the first thing. Also, in terms of the issue of what we want to talk about in this session is we want to make sure that when people do make it to the hospital in the Caribbean, they're met with equipment, with dialysis machines and X-ray machines that are functional. This is important to provide care. And so healthcare engineering is about those systems, the biomedical engineering systems, the IT systems, and some of the finance systems, logistics of supplies that need to be made well. Diaspora has been doing a fantastic job of moving back and forth to the region to provide support, but we have not been doing such a good job of helping in the infrastructure needs. And we're going to be joined, last but not least, by Joyce Sigelei, who is a healthcare management expert. She comes to us through our partnership with one of our colleagues and a member of the Institute of Industrial and Systems Engineering. And in IISC, I'm an industrial engineer. We have a whole body, is a whole special interest group that only focuses on healthcare systems. And so I've determined that some of my time as a volunteer community leader in ICS is to ensure that I bring an engineering lens to help solve the challenges in healthcare infrastructure in Caribbean. So what I'm going to do is I'm going to ask each of our presenters, we'll begin with Dr. McLean, then Dr. Barrett, Mr. Barrett, and then Ms. Joyce Sigelei, each of you to speak for between 5 and 7 minutes, is laying your thesis on the ground. And what is the thesis? In the case of McLean, two people who are on the ground, what are the challenges? What are the opportunities? What is it you would like to see us in the diaspora do? And we can get started. And then Ms. Sigelei will talk about what is it that they have been doing here in the ecosystem to make sure that clinics and hospitals and community centers across this country on the reservations in rural America are able to benefit as much as they can. Not that there are not challenges, obviously, in America, even in Baltimore, there are problems, as we heard earlier. But how are they using the lens of healthcare systems engineering to improve the service of hospitals and telehealth and all the ways in which engineering matters for healthcare? So with that, I'll ask Dr. McLean to start the conversation with her points of argument.
Awesome. Can everybody hear me?
Mm-hmm.
Okay, awesome. Very good. So first, thank you for the invitation to be a part of this panel and to share some of the things that are near and dear to my heart. So if I were speaking from an on the ground perspective, as far as healthcare in general and really a re-engineering of healthcare specifically in Jamaica. But when I speak as far as Jamaica, I speak also for the greater Caribbean, considering that Jamaica is the largest English-speaking island in CARICOM, and just for the pivotal role that they play. So the main thing is the dialogue, which this is an evidence of that dialogue taking place. So first, there has to be the dialogue, but in having a dialogue, there has to be an invitation of the right stakeholders to the table. So there's been quite a bit of a dialogue over the years, and I've been back in Jamaica for the last 2 years. And there's quite a bit of dialogue, but I think the challenge is getting the right people to the table with the variety of perspective that is needed in order to address the issues. Because it takes a multi-approach in addressing some of the issues. And Dr. Nelson, you clearly and very eloquently articulated the fact of what the core of this is. It's a engineering, it's a birth and a rebirth of what used to be. And I think, and I agree with you that now is the opportunity to really address it. So when we're looking from on the ground, there are pillars that we need to focus on. And I think this goes back to what you were saying. And in my mind, in thinking about pillars, from grassroots, we're talking about things like IT capabilities. So that has to be a core pillar when we're thinking about how we would restructure this. The biomedical engineer is another pillar. It has to be another pillar in this whole scheme, because some of the challenges that are currently being faced here in the island is related to the biomedical aspect. For example, broken machines. And so there's a backlog of people waiting to get examinations for machines that, we should have someone on the ready to get those repaired, the service agreements, but that's like really getting into the weeds with that. So that's how I see that as well. Another big component are the people. So the people are probably the core and the heartbeat of the whole thing. And not only is it just about the competencies of folks and how they get trained, but it also is about the mental health, the caring for those folks who are caring for others. What measures do we have in place? But one of the big things for people when you're thinking about personnel and human factors is the communication. And that is something that is a unique entity, not just to healthcare, but across the world. However, communication or the lack thereof has been proven to be the number one cause for errors in medical healthcare provision. So that is huge. Then another part would be, of course, the government and having that support from the legislature, from the policy, the procedures at the national level, and engaging other government entities across the Caribbean as well. That's why that would have to be a critical part, in my opinion, as to remedying that. And then another really big one that I think spills over into all of these ones that I've mentioned is infrastructure. So the literal geographical layout of the island, the lack of access to remote areas, and whether that's access in the physical access or the access in the IT capability access. Because even though there's a challenge with the physical access, we can't remedy that with the IT because of the lack of build out within the island when it comes to roads, having internet, even Wi-Fi available to people in remote areas, and let alone even trying to leverage telemedicine. So those are some of the things that I see as far as pieces of the puzzle, or parts of the cake, making the ingredients to this whole rebirth that we are talking about. So that's kind of how I would summarize that. And I had myself on a 5-minute reminder so I wouldn't go over. Mm-hmm. So that's kind of the summary that I would have initially.
Thank you so much. Next up is Mr. Barrett.
Thank you, ma'am. Good morning to everyone. Let me just start off by just briefly telling you my current involvement with the health sector, particularly with relevance to this topic. I currently lecture in a Master of Health Administration program at one of the universities, University of Technology, where the students principally are senior members of the medical system, both private and public. So hospital managers, administrators, doctors, nurses, and so on. At the other university at the West Indies, I lecture to final year engineering students in essentially a business course, business type management course, teaching them business and management and decision making. And in the faculty, we just became a faculty about 5 years ago. I assisted in introducing biomedical engineering, graduated the first class maybe 2 years ago. And they are part of the group that I teach. And there is, that class size is currently, we're doing about 20 students per year. So that's on the biomedical area. Me personally, my focus has been national health financing. I heard earlier talk about insurance and health insurance. And national health financing is an aspect, is one approach to providing assistance to the population on the basis of universal health coverage. To emphasize, universal health coverage is not something that countries are allowed to define. Universal health coverage means that all health care is available to all residents, human residents of that particular physical space. So in some of the countries in the Caribbean that I've worked in, Bahamas, good example, Antigua, and others, it's an issue because, like in the Bahamas, the migrant population is larger than the resident native population. So it faces a financial challenge for them to enforce and implement universal health coverage as it is meant to be. Now, in my summary, looking at this topic, I really see it similar to what Dr. McLean just talked about. It's looking at the resources that are needed to deliver healthcare. In my advice to governments, I have a phrase that I use. I tell them, healthcare is a social good. Medical care is a business. You confuse the two at your peril as a government. In looking at it, engineering is talking about the physical and technological resources. Management is talking about how we use the resources, the effectiveness, efficiency, quality, and most important, the caring that we can deliver, the system can deliver from using these resources. Now, this is geared towards the diaspora who are seeking to assist, I suppose. What has been done and what is being looked at? I was part of the team that was engaged to develop a 10-year strategic plan in Jamaica. I've been involved in developing country strategic plans in some of the other islands in the Caribbean also. But on the management side, I think the most significant thing that we pointed out was to reduce the cost of administration in the system. In our view, and certainly in my view, healthcare, as is typical globally, money is not the issue. Let me repeat that. Money is not the issue. The issue is the effective and proper use of the money that's there. So, for example, we pointed out that of the projected spend on administrative expenses in the public health system in Jamaica over the period 1919 to 22, roughly $4 billion. They could save 40% of that, 1.6 billion, by just improving the organization and management within the system. Okay? The other thing, in doing that, we also gave a blueprint, step-by-step procedure. Improve the service level agreements, because the current service level agreements don't talk about service, although they provide a tool for the government to effectively manage that. Dr. McLean talked about IT. There's a lot of data that's collected in the system right now. What they need is actually data scientists to improve the use and have greater use of the data that is currently there and collected, believe me, every day. Okay? Another thing was in rationalizing the management of facilities. I like to give the example we gave them. You pick an area, and in this case, it was out west, and you have a type A hospital, which is a premium type hospital. That hospital is struggling at 95 to 97% bed occupancy. And within 20 minutes drive of that facility, one to the east, one to the west, are two type C facilities that are operating at less than 70%. So what happens is, because of the geography and all, let's call it regionalism, we manage by parishes. So those two type C hospitals are in two different parishes. So they manage differently and separately from the type A hospital, but all three are in the same health region. And we're saying, no, you need to drop those barriers and focus on the more efficient and effective use of your resources. And finally, service delivery. The whole point of having regional health authorities and decentralizing the delivery of healthcare in particular is to allow these smaller areas to adjust and ensure that their service delivery is relevant to the immediate population that they're serving. And how do we determine this relevancy? By taking into account factors like the demography of the population. Is it aged? Is it young? The epidemiology. What are the factors of illness that affect them? And also the social and economic determinants. What can they afford? What are the cultural patterns that they follow? And so these are the areas that I think need emphasis and support. And if the diaspora or someone outside is seeking to find out how they can infuse and provide support to the system, I would suggest looking at some of these areas. Don't look at it globally. Focus on particular aspects of the system and decide, okay, we are going to address that. We're going to address that. You talk about providing equipment. That's all well and good. But as Dr. McLean pointed out, you provide the equipment. I won't give stories that I've seen, not only in Jamaica, other parts of the Caribbean. A brand new piece of X-ray equipment is bought and placed, and it's in the crates for 3 years, unopened, because you don't have the other resources to back it up. So it is that kind of case that needs to be identified, and you focus on providing support to the expertise that is here, so they can perform more efficiently and more effectively. Thank you. I hope I've done the 5 minutes. I
Thank
didn't
you
have a
so much.
timer.
Thank you so much for that starting. I just say in cricket, that starting engagement. Now let's go to Miss Joyce Sigelei. Thank you, Joyce. The floor is yours.
Good morning. Can you hear me okay?
Yes, we're hearing you.
Great. And thank you so much for this opportunity to be here today. This is all just very exciting. And, you know, some of the challenges that you're facing, you know, in the Caribbean are just as much some of the challenges that we're facing in the US, especially coming out of the pandemic. I wish I could say, if we go back kind of pre-pandemic, I mean, certainly there's a lot of very successful things in place in the US, but as we have experienced, during the pandemic, we've definitely experienced some of the same things that you're talking about: supply chain issues, service delivery issues, resources, both from a personnel standpoint as well as supply and capital. It's all a challenge, for everybody as we are experiencing, I hate to say it, unprecedented times, but that's really, what we have gone through. I like Dr. Nelson mentioned earlier, I am an industrial engineer and have been in healthcare the majority of my career, and have really had the opportunity to see over the past 20 plus years, how healthcare has changed and how we've been able to utilize industrial engineers in several of these factors in order for us to be able to create operations improvement, process improvements, supply chain management, efficiency operations. And I would say that probably one of the areas that I've focused a lot of my career has actually been in healthcare labor management. So to kind of circle back to some of what Dr. McLean and even Mr. Barrett spoke about from the personnel resource standpoint, is I think that it's so critical for us to really able to help identify folks and knowing where we have the needs and the issues, and then being able to work in partnership, whether it's with schools, and it could be at any level of the schools, to get students and folks interested in healthcare, and then being able to help support them so that they can have a successful career and being able to come into the different healthcare organizations and being able to provide those resources we need. Now, Mr. Barrett, you're speaking about, a piece of equipment, you had the capital item, but you may not have had the personnel to run that item to be able to do it. And I think that that's where some of the challenges come in. And in order to kind of even break it down, we may have to get to the point of looking at each item by item and being able to identify a prioritization, and then coming up with action plans about how to address each and every one of those items, maybe at the higher level, at the more, global or national or regional level, but then at the individual facility level or individual region to be able to determine how to actualize that, because that's where the challenges come. And each and every area may have their own unique set of challenges, but being able to use, some of, to kind of tap in about some of the industrial engineer tools. There's so many out there. I know some of the bigger terminologies right now are things like Lean and Six Sigma, but being able to identify a problem, come up with the action plan, being able to identify like an A3, set up projects. I think that's where industrial engineers have really been able to come in and help kind of, get down into the details of being able to make these actions come to reality, because that's the challenge. And I think some of what you're speaking about too, and you come up with maybe a strategic plan, but then being able to make that strategic plan a reality and actualize it. I would like to also speak to the fact that all of these are challenges, and I know that we definitely can look to the US for some things that have been successful. There's several things out there. I know IISE, the professional organization, also has different classes and certifications, but also has different partners in our different healthcare systems where we can lean into each other to learn maybe what have worked well in one area that could work well in another. And sometimes that just becomes very specific in nature. So for example, I know my specific healthcare organization is very strong in obstetrics and surgical services and imaging services. So sometimes it's nice, if that's where you're struggling, to be able to look at a healthcare system what they have done to be able to tap into them to see what may be applicable that you could utilize to make a difference at your specific healthcare organization. So again, I'm trying to keep to the 5 minutes. I'm more than happy to answer, any questions, but I'm so glad that we're having these opportunities to talk about these things, because we're all challenged kind of coming out of the pandemic of where we're headed over the next several years in order to be able to provide the most efficient and effective healthcare to all of our patients and all of our communities.
All right, thank you so much. So now we can get started in a discussion that is going to hopefully lead us to some actionable items. The whole point is come out of here with some actionable items that could go one into an advocacy paper, but actually could go into advocacy paper so that it can actually be a project proposal or something. Some things we can do on our own, as you well know, and some things we will have to kick it up further to get support. But so let's get started. So you mentioned a popular story, and I wasn't sure if it's a real story or if it's just, but Mr. Bartry said, people send machine and it stays 3 years on the dock because other pieces aren't there. So is this one of these urban folk tales, or is it really a reality? Because I just want to make sure.
Let me correct you. Yeah, no, let me correct you. It's not on the dock. It is in the facility. In the facility.
Okay.
In the facility. And I mean, I have seen this more than once in Jamaica. I've seen it in St. Lucia. I've seen it in Antigua. I've seen it in Suriname. It is an unfortunate thing. What happens? Two things. They get a loan and they need to spend the money, so they buy the equipment without any thought of the support. Or somebody comes along and wants to make a donation and they give them a piece of equipment without any thought of the support. So I keep saying to them, hang on a minute. If you're going to get the financing to purchase the item, first of all, like in Jamaica, one of the things that we've suggested to the ministry is to establish, they have an engineer and a maintenance unit. God bless them. But what they need is to staff it and then have some policy. So if you're going to have X-ray machines, at least depending on the size of the place in Jamaica, maybe you can afford to have 3 different brands or types. But in St. Lucia, there's no point in having more than one type, whichever it is. This is not seeking to give a monopoly or whatever. So it is these kinds of practical things that I say that need to be done. A lot of times they complain that the outside influences that are providing the equipment and so on don't seek their input beforehand. So they're sort of just presented with this piece of machine, and you got a dialysis machine or you got an MRI, and they quote unquote can't use it. So I'm just saying at that level.
But again, here's where I think if we had proper management and proper forward thinking, strategic planning, strategic foresight, if we know that we have a vision 2030 in the case of Jamaica. I'm not sure if the OACS has one or other island, but I know Jamaica has a vision 2030. So let's take the vision 2030 for healthcare, for example, and let's say by XYZ date, we want to have hospitals being able to do XYZ. It means that we know we can't afford to necessarily buy some of these things ourselves, but we know that we're able to either get them from donations or get technical assistance grants, or a diaspora is always willing to try and raise funds for something. But then you have to have a strategic plan that says, here is the assets that we have so far. Get support if you don't have all the information from people like Joyce Sigelei or other people who are working in healthcare. Say, let's have a brain trust that says, let's look at where the universe of machines are going and decide what is the life cycle analysis and affordability analysis that we as a developing country need to look at in order to have a 5, 10, 15, 20-year plan based on the life cycle of a piece of equipment. And so this is why I'm saying, if we are going to be helpful right now, our first task is for us to create an ecosystem of civil society advocates like ourselves to begin to operate on us almost like a side, I hate to say it, like a side private sector support, but not to only provide help to the big, rich people, private hospitals, but almost like a pilot project targeting a small, private hospital, maybe like an Andrews, which is run by the church, and say, let us pilot this there, because they may be more open to a conversation about getting support, because they're not a government-run institution that has a whole lot of politics to go alongside it. But I think we should leave here today with some kind of ideas, some concrete ideas of what are some things that we as diaspora can do in partnership with our allies like a Joyce, with you on the ground, to move the ball forward. So I want us to be very focused on that's how we ought to be thinking in this conversation, and not just rehashing what has gone wrong. So I know, Dr. McLean, when you and I were first met, you said you had a lot of ideas you want to bring to the table. I would love to hear some of them, and then we can see how we move this forward. And I'm inviting those of you listening to put in the chat your stories from the field, especially from Island, stories you ever heard which you know to be true. No fantastic, stories about which are YouTube stories, please, because those are sometimes made up. But stories that you know from people who have experienced things, please drop those in the chat, because we want to make sure we're enriching our dialogue with the reality of what people are facing. And of course, if you have ideas or assets of people universities that might be willing to do partnerships, please also begin to think about how do we come together as diaspora with our partners on the ground in the region to move the ball. So Dr. McLean, why don't you help us get started with thinking through this process, this design process?
Yes, so thank you very much. So in listening to our other speakers and yourself, thank you guys for sharing. I was just writing down quite a bit of thoughts here, but just going back to part of my experience, part of my background experience with the U.S. government, more specifically with the VA, with the Department of Defense in general, and a couple international entities, Panama and Mexico. The approach that I usually take from an instructional design perspective or curriculum development, so to speak, and thinking of what Mr. Barrett said with medicine being a business, we have to keep that at the forefront, because that is really what it is. And it really comes down to the what's in it for me. And when you talk about insurance companies and big systems, it does come down to the dollar value, because we know what has happened with healthcare in the United States, where it has evolved to the point where hospitals have to ensure that they meet the key indicators, that they meet all of those factors for the Center for Medicaid, Medicare Services. They're caring for a big population from that. And so there is an accountability factor that is there. So there's the what's in it for me. So they know that if they don't meet certain measures, that they're going to be dinged for it, to not to trivialize the statements. So kind of keeping that in mind and listening to what we've said to this point, we have to we know there are issues, and we could share stories on end, but we have to then take the scientific approach that is going to establish a basic foundation for everybody who's involved to understand what it is that we're doing and why we're doing what we're doing. But then number two, to put or to memorialize and to put in history an opportunity for others to come and build on that, or for others to come and improve that. It's just like if you're doing research and you publish about a particular area, the hope is that you identify gaps in that exists in the research that could be improved upon. You look at the limitations, and the limitations give other researchers ideas of how they could take that research and either replicate the research exactly with a different population, or come with another perspective. So the perspective of individuals who are involved, whether that's the diaspora, wherever we take it, the government, we have to come on the same level. Well, how do we do that? So first, we know there are issues. But we have to articulate those issues in a scientific way with the numbers, with the data. And that's initiating a needs assessment, whatever we want to call it. Do some research, whether it's with a particular hospital. And I do like that approach, Dr. Nelson, because it goes back to what Ms. Siegel had said about, we do want to have that level, but we also want to start, at a small or a controlled level at the baseline, where we don't have too many people involved, and it becomes just like history has proven, where you have too many people involved and then the energy is diverted in the wrong area. So with that focus, so let's say it was an Andrews, what are the issues? We're outsiders looking in and we think we have a good idea of what's going on, but there are people who live it every day, people at all different levels. And Mr. Barrett articulated the different levels, the different expertise. Who knew that there was a biomedical engineer program in Jamaica? Oh, I was just shocked. I was like writing things down, because that factor, as a side note, we have to figure out how to stop the bleed, i.e. the brain drain of these folks who are going through training, and we are going to lose them because we don't have the resources, we don't have the incentives, we don't have the opportunities for these folks to implement what it is that they're learning. But back to the needs analysis, we have to understand the issues. Sometimes the issues aren't always what we think they are. Things in the rear view mirror may appear closer than they really are. And when we have that data that everybody can sink their teeth into and understand what the challenges are, because I guarantee you it's going to expose ones that we won't even discuss here today. And we have that, then we can start to approach from a strategic perspective all of these great ideas that have been put forth. But if we address the issues that we think without truly understanding the nature of the problem, we're going to be down another rabbit hole just like everybody else. It's like a patient comes in, a patient says, "Doctor, my head hurts." Okay, well, it's not like we're, taking aspirin years ago, like what, physicians would say. There are procedures and steps that this physician will go through, or this healthcare practitioner, to diagnose what the problem is. A headache could be a tumor, could be a stroke, it could be a bleed, it could be the dehydration. There's so many different factors. And even then, sometimes you still don't necessarily have the answer, but you have an approach, and you go through your approaches and you test what it is that might work for the patient and what might remove the headache. So my point is, we have to assess the problems, and whatever those are, we can only know that by truly doing research to expose those things that we need to then lay out strategies and come up with different things with the Lean Six, with the Six Sigma. A lot of those things, the analysis will show us the opportunities that we have to address that. So that would be my first recommendation.
Question, Dr. Barrett, Mr. Barrett, before you go forward. I'm wondering, Joyce, because in the realm of then what we can do and what we can start from, is it that, let's say, for example, we were blessed to have a partnership with a university like NCU, for example. They have a business program, they have an engineering school, and they have a nursing program. And we're able to talk to the president and say, oh, we're happy to give scholarships to 10 people to do a Lean Six Sigma training, with the caveat that they must now become our local research team to do this asset map, because somebody has to do the asset map. I'm already thinking that, suppose nobody wants to fund us, what do we do? Are we going to just say, oh, well, we tried with a conversation? I can't operate like that. I have to think about what I can do with what I can control, which is like very little. Is this a good approach in terms of, at least if we have them understanding the way of thinking, right? They go through a 1 week or 2 week Lean Six Sigma program. And then we say to these either nursing students or business students or engineering students, now we're asking you to participate in this study, this survey processes, whatever process. Is that a way to make sure that if we don't have the big funding to bring in big time consultants, we're at least getting a local grassroots community empowerment approach, because I believe at this point in Jamaica, one thing that also has to happen, we have to begin to empower people. We have become disempowered by what I call the I'll have to wax on this one. Let me come down. Let me come down from my like a perch up there. We have been, I've worked for 30 years in international development. And there has been some disempowerment of our people because they have gotten used to missionaries from the World Bank and the IDB and PAHO. I used to live in one of these places that come with ideas and grandiose schemes. And quite oftentimes, the people on the ground are saying to them, but XYZ won't work. And rather than listening and adjust your design process, you say, well, we know what's best. And sometimes we either overprescribe or we underprescribe. Because I've been in a situation where after the earthquake in Haiti, I remember trying to get the IDB to support the teachers with some quick training around using the arts to deal with trauma. And then the response was, they don't have no school. How are they gonna do that? I said, but the children are in the camps with the teachers distressed and depressed. Why can't we send on some Peace Corps people, whoever, run this camp with the teachers, 30 of them, for like 3 days, 4 days, let them figure out what in Haitian culture can be used to deal with the mental trauma. They must have some stories they can reinvent, etc. They must have some folk song, give them some quick tools, and then let the teachers work with the children in the camps. I was looked at as if I was a heretic, and nothing happened. People just wallowed in pity, self-pity, and misery. And so there's a tendency for these organizations sometimes to be peopled and managed by very rigid, check the box type of designers, as opposed to having the critical and creative thinking skills that you have to apply in under-resourced countries. And so I'm wondering, Joyce, you can respond if that be the approach. And then Mr. Barrett, you know the ins and outs of the different circles of this ecosystem. Do you think that might be an approach that we could move gingerly towards so that we don't get stepped on the wrong toes? I mean, how, because you know that also could be a block. We have to be very mindful again of the politics of the space. So first Joyce and then Mr. Barrett.
Thank you, Dr. Nelson. I would almost challenge, I mean, my experience has been, and definitely students are, a great option. I would almost challenge, honestly, to look within your folks, that are already involved, in the different regions, because they're going to know the culture, they're going to know some of the politics, and it's almost more like if they could have the little pieces of training to maybe help them from a Lean Six Sigma perspective, they're going to have the seasoned experiences, and they just need maybe a little bit of education to help with determining a needs assessment, then being able to come up with action item steps to be able to do that. My only maybe reservation with the students is a lot of times they're very savvy from maybe a knowledge base or book knowledge perspective, but maybe not as much with just kind of the actualization and the realization of what you're experiencing. So what I'm suggesting is maybe approach of the people that are there and with whatever maybe their educational backgrounds are, but they have some of that openness and that knowledge base. And it may be just giving them, like you mentioned, it may just be like a couple-day class or something like that, so that they can feel comfortable with the tools that they can utilize to maybe help move things forward.
Okay. It's a lot of stuff that's out there, which I think can be very useful. So far this morning, as I'm listening and knowing what I'm actually dealing with First of all, I see a comment, and Dr. McLean said she was surprised, didn't know that we had a biomedical program. I work with the faculty. It took us about, I actually started off trying to get it done in conjunction with IIT in Chicago, because my son was a student there and I knew the people at IIT, and they came down and they had a biomedical program. They have. And we decided to do one here. And the head of the faculty, we said, let's work on it. And we put it together. And as I said, we're now in the first class graduation, it was last year before, averaging about 20, 25 students. Yes, one of the issues is where do they go? Because you'd be amazed, there is a need, but I don't know what it is. You know, the ministry, the government is not picking them up. Local private hospitals are not picking them up. A couple of them got jobs with distributors, equipment, manufacturers to be here to provide local support for the equipment they're selling. So that's an area that I think can do with some support because the students have financial problems, okay? So in the form of, you know, a scholarship or something. With the master's program at the University of Technology, we average about 10 students a year. We start off typically with double that. Half of them drop out because they can't afford it. And out of that number, every year, I mean, right now I'm turning down, students are approaching me to do research because one of the requirements is a research project. So Joyce, in answer to what you're saying, I think it straddles it because these are students who have senior positions in the system, hospital managers, regional managers, administrators, surgeons, the whole works, okay? And these are senior people who are seeking to improve their administrative and management skills. But one of the requirements of the program is to do a project. And what I've been doing is pushing my research students. I typically don't do maybe more than two, one or two. But I typically, when I do that, I'm turning down half the class who would like me to supervise them. Because as I said, I teach finance, but I also teach decision analysis, decision and statistical analysis. And that's where we're looking at data, looking at what's happening in their place, in their hospital, okay? And I get them in the research to use their data and we answer questions about what's happening there. My last research student, who was out of Maypen Hospital, working in the theater, we did research on COVID and what was the attitude of medical health care professionals to COVID and how that impacted the public. The lady rushed and did research we did between September and November last year, and we still can't get it out. We still can't get it published. I managed through DevX and so on to give it some exposure. Okay. So what I'm saying is that we do have the ability to pull on maybe 2, 3 research students. So here's an area where, and they come from all different areas of the health system. So they're coming from all of the 4 regions. Senior people in the system who can be used, okay, under the research project to do some of this. And if you look at the past research projects that we've done data and looking at in the Northeast, how was the hospital performing in response to dealing with chronic disease, looked at bed occupancy, we look at COVID, all different types of things like that. And they are very interested because certainly in my case, what I do, I encourage my students for the research to tackle a problem that they are having. Okay, we don't want to invent something. You're in the system. What's a problem that you're facing? How can we use research techniques and do the research to solve it? So I think as a start, Claire, looking at what I'm aware of, you know, is here's an aspect where somehow these students need quote unquote financial assistance. But if something is done where we had a program where we could focus them, target them, okay, because the research costs money. A lot of times I have to help the students out of my pocket to just pay for the data analysis. Simple things like that. They do data collection. They have to do it themselves. We can't afford to hire people to go out in the field. So they have to do it themselves. If that could be supported, we could expand the research. Could even have two students working together on one project. So I'm saying there is some resource there. And here is a way by communicating, dealing with in this case, the program at UTech, right? Stephanie Reed is the coordinator there. How can we
Yeah,
tie this in
yeah,
to
I would
use it to
definitely.
provide data?
I think that we are onto possibly a good thing here. If our interest really is looking on the infrastructure systems to see who already is doing work. I do know that Lean Six Sigma, for example, requires students to do research to be certified. They have to do a project to get real certification to move up the chain. And that also costs. So it could be that there has to be some hybrid because most of us in the diaspora who are doing this work are doing it, quote unquote, for the love of our heart. We do hope to find funding, but at this point, I am too stressed out to wait to write a proposal to then get hopefully big funding. I always like to start with who is at the table. That's my operandus of change for the last umpteen years. So I do think this conversation is actually heading somewhere. I get the sense that coming out of this conversation, we can begin to see the possibilities of somebody like Ray Barrett saying, okay, I can help with finding 5 students who have to do research. So they can do the stuff themselves, but they need to have the software. Maybe it's easier for us to find Caribbean people who are professors in university who already have access to the software. For example, we say, okay, I can put them on my team, or you know what, I'm doing a research project, I can bring them in as my local researchers. And this issue of publishing, for example, we don't have to necessarily wait for a big journal to publish. We can create our own system. I know IISC, SIG, for the special interest group, for example, they do have like smaller magazine type places you can publish your articles and your essays, etc. So for those students who are not necessarily interested in being academicians, they can publish in a magazine, on a blog. So maybe one of the things that also we need to talk about today is how do we also foster an industry association type perspective? Because one of the things that I like about America and I love about being in Washington, D.C. is that there's an industry association for almost every single striking industry in America have an association. I mean, you have the Balloon Manufacturers Association, the Balloon Blowers Association. I mean, really. So we need to have the people on the healthcare, hospital care, biomedical care management side recognizing, just like how you have a doctor's association and a nurses association, you guys need to be organized. You cannot go it alone and try to solve a problem by yourself. You need to have an industry association that's looking at saying, okay, we've gone to school, we now have a master's degree, but we come back into the same old building and the same old system. The only way to have the system change is enough people band together. And it may only be 3 to start, and that's okay. And I say this with authority because those of you who know me know I'm a White House champion of change. Why? Because I was able to get the IDB to change. The IDB didn't want to change. So I was considered, Black Panther. When she's coming at her, that girl, Claire Nelson, she's a troublemaker. But I was able to have allies who sometimes had to hide themselves. But I would protect them, of course, because I knew I was the one that would have to take the fall if something went wrong. But my point is, they have to begin to organize both within the system, but the professional association gives them a structure to organize outside the system, which then is more neutral and nobody is at risk because it's the association that is saying XYZ, not the individual. How do you think this could work, Dr. McLean and Mr. Barrett, in Jamaica and the Caribbean? And Joyce, tell me, is this what you have found, or I see you put them behind, is this what works in America in terms of getting stuff moving?
Yeah, and I apologize. I'm going to have to drop off shortly, but I'll try to jump back in as soon as I can. And let me just clarify one thing. I totally understand what you're saying about like Lean Six Sigma, like they have the green belts and the black belts and all those types of things. And that can be a little bit of a longer process. I guess what I'm suggesting is even just they have like, you know, basic kind of introductory classes, you know, like a white belt or a yellow belt, even where it's just really kind of introducing the terms and the tools and the resources, as opposed to making it be a big, long, you know, process. I think just having that understanding and that knowledge, or utilizing people, because I think that that creates a whole other, you know, thing that may be more of a future state type of thing than like a quick fix. But yeah, I think that those are great points. I think it is a matter of, you know, just even getting a few people together to help, you know, put a plan. And if we, like we're talking about, if we can get down into like at the, you know, hospital level or the health system level or the regional level and just work in amongst themselves, you know, just a few people to start to do the needs assessment and to do those types of things, I think that's going to carry a lot of weight. I mean, it's nice to talk about the whole big picture, but sometimes that's very difficult to actually put, you know, paper to pen and start to make a difference and have action items.
Thank you. Thank you. Thank you, Joyce. I hope you can come back, but if you can't come back, we understand. And I'll be calling on you after the fact anyway to let you know how we might need your help going forward. So thank you for being here.
Thank you. I'll try to jump back in. So thank you.
Thank you.
Right.
So Dr. McLean, you're saying here, I'm thinking of a consortium approach. Could you explain further what that means for you?
So just based on previous experience in working as the director at the College of Medicine in Tampa, when we had consortium, so think healthcare. So anything I'm talking about is healthcare and also business, because that's what I have my doctorate degree in business administration, specializing in strategy and innovation. So this is like right up my alley. But the consortium approach is having representatives from different, you know, focus points. So like Mr. Barrett, I would see as a person, and we're talking about initial, and it doesn't take, you know, too much commitment, but it does take some of the time because we're putting time into it. But we have folks with their skill sets would speak to what we already think are the issues, because those perspectives are going to be important in forming what we're going to call the needs, you know, assessment, because the questions have to matter. The questions have to make sense, and it has to speak to the different folks who would be getting this survey, even if we're thinking of one institution. And that would be at the ground level, but then, you know, a bigger idea is a consortium at the regional level. So for me, years of training in healthcare simulation has allowed us to formalize who we are over the last 20 years, because now we have international societies that came out of consortiums, came out of a small group of people meeting, and just such these conversations is what led to some of those things, you know. So it does work, but what that does when we have those representatives, eventually you have to appreciate that those folks bring with them their network. And so when you bring in these network, then you have an opportunity to leverage resources, to leverage, you know, capital, to leverage intellect, because intellect is one of those things that you cannot put a dollar value on, but it's one of the most priceless things. And form, and once you're together, that consortium takes on a life of its own in being productive. You know, if it's geared the right way. So that's what I was assuming, or that's what I was alluding to as far as a consortium, because one of the things that I wrote down was, you know, we have to take an innovative approach using kind of that whole consortium perspective. Because for this time, post-COVID, where we're all competing for the same limited resources, and we're still taking the same approaches that worked prior to COVID, which are not going to be working effectively post-COVID, it's just important for us to look at that approach in an innovative way?
Yeah, I think this idea for consortium, we already have structured what we call a health working group just for the general policy statement. But this research consortium that could be either national or regional would be a good approach. I do think it's important to have some entity that can also be the one to whom a diaspora who are interested in this can eventually have a partnership. Because when we talk about biomedical engineering, for example, I just found out about the program last week and I was doing research like biomedical in the Caribbean, because last year when I was trying to find somebody, we're looking, it never came up. So even the search engine didn't show it up last year. It came up this year when I was doing my search engine. So my point is that there is obviously a need to also educate the stakeholders about what has to happen. People think that the doctor is the doctor and the nurse is the nurse. And that's when they think about medicine, and the pharmacist. They think about those three people and nothing else. And so it is up to us to educate the consumer, educate the government agencies themselves, who, even though they might have been trained, still instinctively think doctor, nurse, pharmacist, and that is the end of how I do a healthcare system. So it may be that a school like NCU might become a wonderful partner. In fact, I really think that NCU should just be specializing in healthcare and engineering and nothing else, and don't want to take on other tourism and all those other madnesses, because other schools can do that. I mean, I think as a small school with small resources, if they can help solve the healthcare problem, solve some of the engineering, agriculture, engineering, food security problems, because the whole, especially as a school out of a faith system, if you can provide the physical care to the body of man, quote unquote, food, water, shelter, they've done their job in terms of their role as a school founded by a community of faith. So this consortium idea, Mr. Barrett, do you think that we should keep it informal in the sense that, as opposed to having institutions, because I'm worried about institutionalizing something. Right. I would prefer for individuals, those of us on the table, those of us who are not here right now necessarily, but we will be able to, bring on board who are in hospitals here, keep it agile, because we don't have to stand on a sermon and get anything approved. We can speak as we want to speak, and have it outside the system. We create a new system that could eventually become what in my head is the Caribbean Healthcare Foundation, that is really about empowering practitioners and consumers to understand their healthcare rights, their human rights in health, and to also give back, if you will. Because I know one area, which nothing to do with this conversation, but when my mother had Alzheimer's, I was frantically trying to find some group to which I could even join to, give my support, to bring Alzheimer's education or whatever. I couldn't find nowhere to go. So we need to have these ecosystem developments to strengthen our way of being together in the world. I see your hand up, Dr. McLean. So
I was gonna see if Mr. Barrett wanted to. I'll tag in after him.
Okay.
Go ahead and
Okay.
Sure, thanks. No, I very much like that idea and the approach you're suggesting. I agree with. I am not a quote unquote institutional person. So based on what hearing Dr. McLean describe it, I think yes. Early on, somebody mentioned policy versus the day-to-day on-the-ground things. No, the strategic thing. One, combine them. As you said, you gave a term there, was it? Caribbean Healthcare or whatever, Foundation, right? Okay, that could be the terminology. And yes, what it consists of is a group of persons collected, okay, under this umbrella of the foundation to address these things. Now, typically, when I've been involved in some of these similar things, what happens is that we're collected, and in the initial phases, we expound. You want to have free talk, everybody comes up with the ideas. And out of that, we distill it into okay, what are the 5 things? What are the 3 things that we're going to have as themes, or we're going to focus on, concentrate on? Okay. Not to say that over time it doesn't evolve,
Right.
but it gives you a start. As you say, you keep it practical. Okay. And you have these people come in. And then in doing that, you're looking, when you start to formulate that, typically somebody has to take on the leadership role. And when you have it formed like that, that actually, well, clear you have more experience here, I suppose, is what could help you to now mobilize support, financial support to get things done, because but at least what that group is doing. And as you say, it's agile, it's flexible, it's it's amorphous. So it's a group of people, and I like thinkers, yeah. I suppose I'm too academic, but I like thinkers. So you want people who are thinking, and that's what we're doing. It's free talk for free thought. Get the ideas out. We have to be distilled. After distill it, 'cause we can't tackle everything, right? So the priorities will come out. And I just mean, just out of what has happened here this morning, as I'm saying, I'm really embarrassed that nobody knows of this biomedical program. Good heavens. And they're turning down students. They have more applications that they can cope with. And the students need financial assistance. But the problem, as I said, we just had the first graduation, right? Going into the second one is getting them placed, because we're not, certainly not you, we have no desire to be training people, quote unquote, for export. Sure, people are free and are going to leave, but we want us, having identified a need, to at least see them going into that need. But the system, so I mean, I must admit, based on what I'm hearing here this morning, I'm busy for the rest of the day, but I can tell you, tomorrow I'm going to be calling Paul and them and saying, what the hell? No, I've just come on and sing it. Nobody knows about it. And this was such a big deal, because we are the first. Trinidad engineering faculty does not for biomedical engineering. And just a brief, I'm a storyteller, but just a brief aside, how it really came about. My son went, as I said, to this college in Chicago, and there was another Jamaican fellow who got in there, but he couldn't afford it. He was having financial problems, and he was doing my biomedical engineering. And my son said, Daddy, this guy really needs help. I said, okay. So I funded him for his last 2 years. And I funded him on the basis, when you finish, come back to Jamaica and just give us at least 3 years. That's all I ask you to do. There's no contract signed, nothing. But I'm just saying to you, I'm going to fund you, and just asking you to come back for the last 3 years. He never did. And where he ended up on? Wall Street. Did biomedical engineering, and he's on Wall Street making a bag of money. And I'm saying, good God. I mean, no, that's not, that's not the point, okay? So we have this there. We in faculty engineering missing something. But the point is, came up with it, there is a need, okay? And I think one of the things that this consortium foundation needs to look at, as I was trying to say earlier, no point in putting the resources and they're not going to be used. So we have to ensure, that's why I link the policy with it, Dr. McLean, I want those two things in, because it's integral. That's right.
Absolutely.
When we have the policy, this is the policy, and this is how we're going to implement. We're going to make the investment here. We're going to buy the equipment, and we're going to build the facility. We're going to reorganize. That's how we get into it. And that's why what I like about my MHA program is that I'm teaching to people who are in the system. These are people in their 40s, right? So these are not people who've just graduated from university and looking to get a master's. These are people who have been senior in the system, they've been in the system. And that's why I say to them, for my research students, I want you to research a problem that you are having. Let's not go make up and hear what somebody, you, because you have the personal experience of it. What's the problem? And what we're looking at for the research is to identify, document it, and come up with a solution.
Yep.
So
So I
we're
love it.
being joined by Dr. Bradley Charon, who is in Tobago. He's in his scrubs, as you can see. He said he really wanted to be on this call. In fact, I delayed in sending him the link. I was so busy moving back and forth. He really wanted to be on this session because he's very concerned. Just to bring him up to speed, what we've been talking about so far is largely what we can do with the biomedical systems in Jamaica. Turns out there's a biomedical engineering department in the University of West Indies. And what we have come to is that we want to try and make sure when we leave this call, we have some things to do. So we want to definitely hear from you, but I just want to bring you up to where we are. So what we're talking about when you join is just the fact that we've said, well, maybe we have to create a consortium and research consortium to do this asset map to see what really are the problems, and then we'll do some training of people already in the system just to get a pilot started. So we have identified a potential pilot in Jamaica that we can self-do without any external funding, and maybe you can think through that as you talk about your experience in the twin island of Tobago, which is not the big island, which has its own level of distance from, from the center, and then see if we can have maybe 2 trials at the same time, one in Jamaica and one in Tobago, out of which we can then go to an AID or a PAHO or an IDD and say, look, this is what we have demonstrated that could be done. And here's some initial research. Now we need funding to move it forward. We already have the partners in X university. In other words, we want partners that we already vetted and trusted. We don't want people to come in just because it's a project that they won, right? We want it to be more realistic. So your floor is yours, Dr. Bradley.
Hi. Thank you for having me. And good afternoon to everyone. First things first, I would like to thank Dr. Nielsen for at least allowing me to participate and invite me, even though it's been delayed. No problem. Thank you still. And biomedical engineering was one of my first choices when I wanted to start medical school. So I was stuck between engineering and medicine. So I started engineering first. My family always wanted me to be a doctor, but I said, I don't like when people force me to do something. So I went to engineering with my girlfriend. However, my dad was right. And I moved on to medical school 2 months after being in engineering. So with that in mind, I do see the need for biomedical engineering here. But when I applied, which was about greater than 10 years ago, there was no program in the Caribbean that I knew of.
No.
And the only option was in Florida. And it didn't seem quite financially feasible, or even if it was financially feasible at that point, returning home, job opportunities seemed to be scarce at that point in terms of finding proper job opportunities, or even being aware that there were job opportunities. Now that I've gained some experience in both internationally, because I went to school at St. George's University. So I was in Grenada for 3 years and New York for 2 years. So my clinical training was done in New York. Then I returned home. I did my internship. I actually returned to Grenada, did research for 2 years, got published in anatomy, left and came home, worked in the system, did internship at Port of Spain, worked in surgery for 2 years at Mount Hope, worked in surgery for 2 years in San Fernando, and recently switched into primary care and moved to Tobago for the opportunity, because there's very little opportunity in primary care in Trinidad because it's oversubscribed. The difference is I couldn't function properly with the equipment we have down here. And having this forum, I think it's a great start of finding ways to, first of all, assess and evaluate what we have, and then move forward to see what is current and the first world platform, or the most up-to-date equipment, or what's the next best step, because the management that I learned was always the next best step, not what we have available. And I think that paradigm needs to be shifted from the third world. If I'm incorrect, someone please step in. Hello?
Yeah.
He's asking if he's
Oh.
incorrect. If somebody please step in. You guys are underground at home in Jamaica.
Yeah, that's why we, yeah.
Fully agree, fully agree.
Yeah, we didn't step in because we agree.
Yeah.
Oh, okay. Got you. Yeah.
And I'm
So
familiar with St. George's University. I'm Grenadian born, so go ahead.
I think of Grenada as my second home. I love Grenada, and that's why Tobago, like, even though it is my home, it is more my home because it has that Grenada feel as well as Trinidad and Tobago in one. So I think I've found my niche and my home for the rest of my life now, so I can stop drifting around the world. With that in mind, my family is of a background in healthcare. My father's a pharmacist. I have a deceased brother who is a nurse. My other brother is into project management, but his wife is a rheumatologist in London. And well, my mom is deceased, but she used to manage the pharmacies that my father and her owned. And now that I'm here in Tobago, I see so much opportunity for healthcare and medical tourism. There's the quantity of funding and the equipment that I see here. It is excellent compared to what we have in Trinidad, because I've seen the hospitals in Trinidad. However, the flip side to it is that we have state-of-the-art equipment with no one to use it.
Mm.
And I was in Trinidad and I never knew Tobago had basically American equipment. First, the things that I was trained on and I learned, they're much more advanced than they actually had in New York. Everything is touchscreen. There are multiple monitors, and that everything is continuous vital monitoring and touchscreen in Tobago. And they're excess in dialysis machines. They're excess in theater, in ventilators. There's an MRI machine that's not being used. There's a vascular lab, a cath lab that is unutilized.
Wow.
And,
so you will have a flip problem. So, but this is interesting because, you know, I hear, for example, I am hearing, for example, that I've seen where Jampro said we will do medical tourism in Jamaica. So I start laughing. I'm like, are you serious? Jamaica medical tourism? I mean, seriously, this would be such a travesty. But the Caribbean in general could have positioned itself as a medical tourism haven, because we certainly have a reputation of having good doctors. We have a reputation of having excellent nurses. We have good climate, good, you know, food, etc. But we don't have the infrastructure. So maybe a long-term vision of this consortium, because it's one thing to solve a problem, but how are we going to pay for it, right? So maybe the consortium should be thinking about, okay, since we know that medical tourism as practiced in XYZ countries, Brazil or Indonesia, etc., rely on these factors, on a secondary research area, once we get the first problem solved just for the care of the people here, is if we're going to sustain the healthcare for people who can't pay, how can we create a model that allows us to subsidize the cost of healthcare for those who can't pay? So this equipment can be used, but the people who can afford to pay for it can have access. So I think this is what I'd like to see, this research consortium. What we talked about, Dr. Brad, is that what we want to do is go a little bit outside the system and create a parallel organization network of researchers and industry interested partners that want to look at healthcare as a human right, but recognize that it can't be based on a charity model. So we have to very early begin to think about how is it going to be sustainable. It's one thing to say we're going to get a grant to start it, but we cannot live off grants for the rest of our lives. So how are we going to end up paying for it? So that's the kind of conversation. We have about half an hour left in our discussion.
If you all may allow me to continue, I have something that I did try to propose. So I'm a young man, I'm 33 years old, and I was hired to go to work at one of the new hospitals in Tobago. It's Roxborough Hospital. It's a brand new facility, and it is fully equipped with emergency department, all your core specialties for housing in terms of wards, miniature wards. However, all 5 specialty capabilities, the operating theater, a dialysis unit, and it is unused. So I proposed to one of the members of parliament, well, one of the members of the THA at that particular point, about having, as you said, it's an investment that was made. However, for 2 years, it hasn't functioned in its capacity. And because it's government funded and government will never be able to have a return on its investment in that structure, you wasted it for 2 years. So you didn't get the outcome of that funded hospital, right? I proposed a method to get a return on your investment and not recreate the wheel. Just use the English model of a public-private partnership. And I was willing to, as you said, take care of the people who can't afford it, but to get first world or state-of-the-art healthcare, we can also have religious groups involved. So Trinidad and Tobago has a good diversity when it comes to religion. And I believe there's no disrespect when it comes to religion here. At least I don't see, so as any country might have race disparities or things like that, one thing I've noticed that we are great at in Trinidad and Tobago is respecting religion. So
yes, that's true.
So with that in mind, I wanted to use a model that gave any race, also any religious group, the opportunity for free healthcare, but it has to be supported. So our tax break from the private-public partnership will be to help the people of Trinidad and Tobago, right? And the people around the Caribbean who can pay for this will help generate the income for this place, right? That, on the other hand, we give, and we're not only going to go to the 3 major religions. We're not going to go to Christianity, Hinduism, and Islam. We have Jehovah's Witnesses, we have Shouter Baptists, we have Buddhists, we even have Jain. We might have 1 or 2 Jewish people here. It's variable. But
So,
these are...
I'm not laughing at you, I'm laughing with you when you think about the diversity that exists in such a small place. Go ahead.
But yes, so I went to school, as I said.
And Rastafarians, don't forget
of
the
course, and we have Rastafarians. Of course, yes. Some of my neighbors are Rastafarian, to be honest. I'm shocked I forgot to say it. All right. I apologize if I left with any other religion, but with this great country, when it comes to tolerance, and with one of our Caribbean leaders, like Honorable Mia Motley, if we could copy her tact and method of dealing with world situations like climate change and healthcare is another big factor. Have her approach and not say, hey, let's just wait for the first world to do it. Let them respect us and say, hey, what? We have intelligent people here too. They need to wait. They need to look at us. They're not us wait on them. Can you hold a second, please?
Yeah. While he's gone, let me just say this. I think he's onto something there, because I know a lot of Europeans go to Tobago for long-term tourism, but they may not even know that they could do their elective tour surgeries or whatever when they go on, because they already have a lot of tourists from Germany and Denmark and those places going to Tobago. So really, your idea has merit, because you're really attracting that kind of long-term tourism who may want to do a surgery of a certain kind. The question is, as you say, do you have the surgeons who can use it? So again,
yes, I do.
So then again, the question is, how do you get the government to listen? And this is why I'm saying our approach is, can we create a consortium, first of all, of interested individuals to begin to do some small things so we're taken seriously. So then we come on a project which for them is out the box and sounds slightly crazy. They're able to see that it's not crazy, and we will then have the support of some of these faith-based leaders in the case of Trinidad and Tobago that says, yes, we actually want to be partners, because like a lot of, like the Catholic Church in America runs a lot of hospitals, as you well know. So there's already and it's in partnership with government. So there's already a practice of private partnership between the faith-based community and hospital care, which I think the Caribbean can do a much better job of modeling, because I do think we will get this sort of a mutual respect and mutual empowerment. I'm seeing lots of things in the chat here, and you might all want to read the chat. One is saying, yes, Peter Rene is saying, yes, we have to stop this gimme business. I want. We have enough brilliant minds to lead. And then Chana Hines is saying to place equipment in alternative clinics, etc., etc. These are all models I think that we have to look at. And this is why I'm saying, if coming out of this conversation, if nothing else, we can agree to meet again and have a more in-depth design process discussion, it will be an asset, because I do believe the time has come. COVID has really woken us all up in a way that I have to say, thank God for COVID, quite frankly, because COVID has woken us up in a new way, because many of us were frightened when we realized how behind we were in terms of access to equipment, access to ventilators. We had to rely on people. And the people who were coming up with ideas in the region to provide substitutes couldn't find funding. Dr. McLean, I see your hand up.
Yeah, so thank you, Dr. Bradley, for sharing. And we need to have a conversation, because you have my mind recalling some of the reasons why I moved back to Jamaica. One small point I'd like to point out is, you notice Mr. Barrett says where he's from, but you notice where he currently is. I just thought I'd make that point. I'm just saying, okay, so now that I've made that important point.
Thanks to my dad.
The best island in the Caribbean. Just a few quick things. Going back to what Dr. Nelson had mentioned about education. I actually wrote that point down when you mentioned. I thought, wow, she's brilliant. But I think just coming off of what Joyce talked about with connecting people culturally, even though Dr. Bradley wasn't here, he strengthens that point where she's saying that we want to make sure that these folks who are involved have some connection to the culture, because there's just some things you cannot teach. And having that background understanding that he just articulated comes from that cultural experience. But what I mentioned about with education is there is an important thing for us to re-educate society, including those leaders within the healthcare system. So that's one of the first points that I wrote down. And the knowledge of knowing there's a biomedical engineer program in Jamaica, the Stop the Bleed program that NCU brought to Jamaica earlier this year, come to find out it was actually developed by a Jamaican physician, surgeon in Hartford, Connecticut, Dr. Jacobs, who was a UE grad. So the concept came from Jamaica. Now it's a worldwide thing, that we promote for anybody to do training.
Really? Stop.
Yeah.
What is it? I've never heard of it before.
Okay, so the Stop the Bleed program is a group. It's a consensus that came out of the Hartford meeting. And what Dr. Jacobs saw as a challenge was the response to people who were injured and in saving their lives. And bleeding from trauma is the number one cause for, deaths that should not have happened. So it became a bigger thing. It's kind of like us meeting here. It became a huge thing. It was backed by the White House. It went through legislature. And it's a training program with support from the DOD, where you teach anyone who has two hands, and they're able to apply 3 basic steps to stop someone from bleeding to death. So we launched the program in January of this year. We've gone through maybe over 200 plus people so far. It's a community initiative that we're carrying across the island. So the point is, with saying that, is an example of how these things happen. They're here. A Jamaican doctor came up with that concept, brought in other people. They formed a consortium and a consensus that now it's worldwide. And the goal is to train 200 million people to be able to do that, because that has proven to save lives. World Health Organization supports bystander intervention, as that is one of the leading reasons why people have time to get to healthcare facilities to get help. But 3 more points I want to make real quick is with the name that you mentioned, Dr. Nelson, with the Caribbean Healthcare, I actually wrote down something of the sort, and we can always wordsmith, but Caribbean Healthcare and Biomedical Engineering Foundation. And here's why I think that's important to have the title speak to inclusivity. In working with the military and in working with aviation, a lot of what we do in healthcare for the last 20 years can literally be tracked back to aviation, i.e. or checklists that we use in surgery, or checklists that we use in critical care, in trauma, across hospital systems. That was fine-tuned because of what the pilots have to do before they fly. Mind you, they're trained on thousands of hours of simulated flying before they can actually fly live souls. So we looked across industry, which I think is an important component, and we learned from industry. Military, there's quite a bit of medical things that we do that we got from the military, whether or not we give direct credit. But that importance of having people understand what we're about and seeing that, oh, wow, healthcare and biomedical, because in my last role in the States, we would come up with ideas on the healthcare side. And in our facility, we literally walk down the hall to our biomedical engineer guys and we say, hey, this is what we're thinking. Here are the specifications. What do you think? And we actually could create through 3D printing devices that could be utilized. And some of those went on to go through GLP for FDA and for implementation in clinical practice. So there's some serious things that can be done. And so, I've always just really honored biomedical engineer and what it has done and continues to do for healthcare. But the last point that I wanted to mention was, back to what Mr. Barrett had talked about with this being, possibly a good approach. We have to have actionable items. And I think everybody kind of alluded to that. So I'll tell you just 2 opportunities that have presented itself since I've been here, but I have not had a way to bring it into the island, is a few industry companies who want to relocate their factory and in the Caribbean. Because if you notice, if you really understand industry, especially healthcare industry, you'll notice there's the United States, there's Europe, there's, different places, and Latin America. You're not going to find a whole lot in the Caribbean. So you ask yourself why. Well, there's a long history behind that, but there is that opportunity. They are looking at Jamaica and even supply chain. So there are companies who want to move from China and they want to relocate, and Jamaica, i.e. the Caribbean, is a perfect location for them to relocate. So those are some of the things with identifying where we can tag and say, this is what we're going to be doing. But the biggest thing is setting up the policies, like Mr. Barrett said, making sure that we have the data that ultimately will be what allows us to get funding. So whether that's grants, whether that's from beneficiaries, because that's one of the things that I've done over the years as part of my role. You think about the Roberts Woods Foundation, a lot of these things, it's because someone of theirs almost died in a facility and they want to make sure that people know how to communicate. So they give the rest of their life inheritance to healthcare, so you can track and see all of those things. So we don't have to reinvent the wheel, like someone said, but we really need to make sure that the things that we want to do are measurable, they're action items. But through education, I think both ourselves and the folks that we're re-educating are going to learn about opportunities like what Dr. Bradley shared, learn about opportunities like Mr. Barrett letting us know there's a biomedical engineer program. I keep repeating that because I can't get over it, in Jamaica, and all of these other things that I think are going to, come to light. So those are just the points that I wanted to put out there.
Yep.
The chat has been quite busy and talking about all new ideas. Saying one person is saying yes, Dr. Liebert said yes, tourism has been a backbone of our economies and all tourists have healthcare needs. So, tourists can come and benefit and contribute to healthcare facilities. I do think that should definitely be a serious part of any work we do going forward as a consortium looking to transform healthcare. And I think that if we tie our work to SDG on healthcare, we can find and tie the other things back to it. We find different ways in which to approach the cake and slice it depending on who we're talking to. China Hines is talking about alternative ways to create income once you have something in place to begin to start and train providers on diagnostic equipment, etc., which are income from medical spas. So she already does see, she's just coming out of being trained in this kind of stuff here in the States and seems like she wants to move back home. Or sort of, if not move back home, maybe to go back and forth, that's for sure. Like most of us want to go back and forth, right? Free flow of our time and energies. And so I'm hearing a kind of coalescing about this idea is a time has come and I need not be as upset and frantic and afraid as I've been for the last 4, 5, 6 years. Then COVID hit. I was like, oh no, this is my greatest fear coming to pass. So I must tell you, as we begin to wind down, anybody else that's on the call in the chat that has any specific issues that we didn't raise that you think ought to be raised, now is the time to put it in the chat. We're talking about healthcare infrastructure. We're talking about the biomedical equipment and engineering systems, the allied health systems. We didn't touch on dentistry, but obviously there's an allied health system. We didn't touch on things like eye surgery, which people are going blind because of diabetes. These are all allied health systems, of which are all new technologies are out there that can make it easier for our people to not have to go blind, right? That we need to think about, how do we get diaspora to engage? People have been having fundraising and sending them, as you said earlier, Mr. Barrett, I'm sending them hospital beds that nobody can use. So we have to also train the diaspora, educate the diaspora. We love that you want to give back, but before you give back, here's a foundation you should talk to make sure that what you're giving back works. And eventually what we're going to have is a database that says, here's what it needs. And it'll be online. So they can say, here's what this hospital needs. If you're from Tobago, here's how you can help. If you're so we can help, until we get the system in place where these things can be paid for. We still have to do some, asking for help, but at least let's ask for help that makes sense. Don't just send them a machine because your old hospital getting rid of your old stuff, so they're going to ship it at cost to the countries and then they can't use it. I'm not saying we can't send home used stuff, but the used stuff should not be sent home if it's the end of the life cycle of the thing. If it's midway through the life cycle and have another 5 to 10 years, yes, because then at least we can get parts. But if it's the end of the life cycle of the thing, and that's why they're moving it from your hospital, we don't need it in the region because nobody can fix it. There are no parts to keep it alive. So these are the things we have to educate our well-meaning, loving, giving back diaspora about. That not every gift is a good gift, right? Just like how they don't like old clothes and old shoes, we don't want an old bed that don't work, right? We want to make sure when you're sending, just like how you have to make sure that the medicines that you send to the Caribbean are vetted by the ministry before you send them. We have to vet the machines to make sure they're not end of life cycle, and do it as a program wherein once this consortium gets off the ground and we figure out how we're going to get some support, we can then say, okay, if you send in this machine, we have nobody trained to use it. Therefore, can you also get the manufacturer to support with training? So these are the kind of things we can ask for with very limited resources until we are able to build the capital asset for this resource to be self-financing. And I think we have to think like that. Let us look at a model like Johns Hopkins medical system. Why can't this consortium, if we're going to dream big, it might as well dream big. We're 60 years out of independence this year for Jamaica and Trinidad. And we have a big chat. We're going to be independent and leave the Queen. It's time we talk big and leave the Queen. Okay, fine, wonderful. But having left the Queen and still operating with an enslaved mentality does us no good. So I think that healthcare, the first thing you must have is a healthy population so they can think and they can create and they can even do better things than we have done so far. And I can only imagine if we start thinking of this baby step as a first step to having a Johns Hopkins type consortium that partners with the governments in our variation that can be copied by other small islands in the Pacific, right? Look at it as something we're starting, not just for our region, but for the Alliance of Small Island States. And we have been networking here at ICS with a new organization or network called the American Islands, right? So all these little islands off the coast of America that have to also travel inland for different treatments, etc., they're now organizing because of climate change. And there might be new quote unquote alliances. I understand that they're going to be funded out of the climate partnership. So maybe we can find an element out of that to say, okay, let's see how we can put yourself into this alliance in a tighter way around healthcare facilities being prepared for climate change. Okay, it may not be the original place we want to start, but at least it gets us in the door. So this is these are some ideas I'm throwing out to say I feel very hopeful. A question has come in directed to Mr. Barrett saying, by Dr. Liebert, how difficult is it going to be for us to create an equipment inventory database across the Caribbean islands to facilitate homegrown service provision?
I don't think it is that difficult. It is something that I have been wanting to do, but it takes some money to put it together. Why I say that is because, in fact, when I was looking at it, it was for CARICOM, and people don't realize that CARICOM includes Haiti and Dom But for the English-speaking Caribbean, fortunately, our health systems are based on the public health system. The government dominates, okay? Government is typically 90% of the system. So that one can go to the government and start off in the ministry looking for what records there are to start to put that database together and then validate it by visiting the institutions, okay? So that's the kind of project which I think, as he asked a question there, it would be better if it could be put together as a regional, let's call it a Caribbean program, you know, as a CDB might be able on that basis to get CDB funding and assistance for it, okay? But that is really critical because as you're saying, clear, one of the issues I keep talking about is that what would happen is that when you say, okay, I want to give you some X-ray equipment or dialysis machines, they need to be able to say, okay, this is what we have. So if you give me something that is widely different, it may not be economical for me to even try and support it, or I can't support it. We've had that unfortunate circumstance here where the Italian government has given equipment and they can't afford to support it. And it just, you know, lies there and just goes to naught. So it's a shame. So we need to be proactive. That's why this whole, I mean, really, I want to thank you, Dr. McLean. That idea of the consortium, I think Claire has jumped on it. I think that's something that is definitely worth pursuing. And I would be, you know, more than willing to participate in something like that. No, I think
so let me tell you very clearly. Let me tell you
it out. So let's, you know.
Let me tell you very clearly. We already have a healthcare working group. When Public Law 114291 was formed, and state, it's a law in America that says 114291, which says U.S. State Department must prepare for Congress every 3 years strategic agenda. That was in 2017. They came up with 6 pillars and then they added disaster as a separate one. So we have organized our advocacy paper to basically mirror how State Department is organizing its work. And if they change, we try to change as well. Now, for example, in the era of the Trump administration, they could not mention climate change. So we hid it on the prosperity and sometimes put it on the blue economy as a subtitle. But now it's being brought out as a separate thing as a new administration. How we as ICES and advocates work, we think, okay, here's what we want. And we don't care if we don't want to talk about it. Like they didn't want to talk about agriculture at the time. We still put in our paper because we think we can't feed ourselves. What is the point? We're going to starve to death if anything happens. So we already have a healthcare working group that really needs help to be strengthened. And this conversation and this and the document we have, this conversation, I'm going to ask those of you on this call who are interested in really doing the work to send me an email. My email is in the chat, where you're indicating your interest so I can call you to our next meeting. We can look at the document and we can take out the parts that you want to contribute to, and we work together to get this done. So it's really going to be not just having a talk shop, but when we leave here, we move it forward. That allows us as advocates to work on this side. The consortium is going to be on that side, right? Because you have to have your legs on both sides of the aisle. And ICS, many years ago, we created an organization headquartered in Jamaica called the Caribbean Development Foresight Institute, which was meant to be a catalyst for this kind of a experimenting pilot. So we wouldn't have to, you know, every time we want to do something, have to find somebody who doesn't get where we want to go. So we already have a legal entity that we can certainly give the keys. So it's not a physical body, but it's a legal entity on the paper in Jamaica as a company that we can give the keys of the healthcare consortium to Dr. McLean and to Mr. Barrett and say, hey, you guys are on the ground, you can be the leaders, but because we already have done some things with the embassy in the region, we've done a couple of things, not a lot, but we've done some things and continue to do things little by little. We already have a brand name that has begun to be out there in terms of what we're doing. For example, the Caribbean Space Society that I started at NCU, the club, is run through that entity in the region. So these are ways in which we can get started with very little effort to get the first legs of this movement moving forward, knowing that this meeting of the minds, this consortium will have its own design lab process to create what I'm calling the Smart Caribbean Healthcare Futures. And my SMART means something specific. S is sustainable systems. M is meaningful metrics. A is about the agents in the system being empowered and adaptable and agile, understand that everybody in the system has their own aspiration. R is designing a system for robust resilience. And T is designing the system for ensuring technology transfer, transformative technology transfer. And so the SMART approach, we've been preaching it since 2 years ago. I actually have a book out on it, and we're really getting ready to make sure we don't go back to the old normal, but we create a new normal. And Joyce is back, so hopefully we can rope her in as an ally to support us in getting support from members of IISC to help us with some of this initial training, these one-day training, these two-day trainings that may not require that we seek any big funding format, be something we can do ourselves. And to the stage 2, when people start traveling again, we can say, okay, let's invite you down to the region. We'll put you up for 2 nights if you train us for 2 days. And people might come because people wanted us to travel. And if we can put them up, they may do it for free. So I'm saying there's ways in which we can get support that some people who will give back to other countries in this way. So I want to say thank you all for being here. Really from the bottom of my heart. I'm so grateful. I feel so hopeful. And that for me is the biggest gift. I don't want to become emotional, but I'm getting emotional because having worked so hard and not being able to find people on the ground who get it, who see that we must do for self, who see that we can start off with just the idea and eventually the funding will come, has been a point of great frustration for me. So being on a call with a Ray Barrett, a Dr. Carolyn, a Dr. Bradley for me, and having somebody like Joyce, and let me just say to Joyce in particular, Joyce followed up with me when I dropped the ball and did not call her back. She called back and said, do you still want me to come? I'm not hearing from you. That shows that she's interesting because she doesn't know some Adam, okay? So my point is we have allies like Joyce Sigelei, who is willing to give some time to be here to listen to see how she can help. So I feel really grateful, and I just want to say thank you all for being the answer to my prayer around this issue of healthcare systems engineering and healthcare systems management. Thank you, and have the rest of the day. Have a great day. We're coming up next on the integrative and complementary medicine. Any last words?
Thank you very much for the invitation and the opportunity to meet these other persons. And I really enjoyed it and look forward to meeting you all again.
Same here. Thank you very much.
Thank you very.
Yes.
Thank you very
Thank
much
you very
for
much.
organizing this. I do enjoy all the exchanges.
Yeah.
Awesome.
This Dr. Library, thank you for staying on.
Sure,
So
sure,
folks,
no
we're going to shut the live stream down and we're going to stop our recording and allow us to breathe. Those of you who will be staying on can take a bio break and we'll be right back.